in the same material, but it has the left coronary coming on its own from sinus 1, and it has the circumflex and the right coming off together from sinus 2. So it has a retropulmonary circumflex artery. And Osami is going to show what we studied. He's just getting himself ready so that he can show you the key part of the coronary transfer. And it gives you have one of these models as well. And again, we're going to do this tomorrow, and it gives you another chance to have another sort of another attempt with the material and to do the coronary transfer yourself. So Osami, you're okay there?
Yeah, sounds good. Do you see my screen? Okay, perfect.
Yeah, that's good.
So I did most of the preparation there. So the LeConte already coronary immobilized. This is a 1L2RCx right here. So so this one to describe here. So this one particularly is very interesting because it's bifurcated very early, right? So right after the origin, you have circumflex, and then right coronary, and then circumflex. Can you over here just very gently, yeah. Hugs around this right posteriorly, and then so here. This is really kind of being stuck to the roof of the atrial wall, right? So you don't need to dissect all hole here, but the key here is very different that you had to manage this angle right here, this kind of free part. Otherwise, it's kinks. So I'm just gonna, and for the close technique, again, can you grab me? So I just mark the anterior commissure, just nice and low, and then I'm just gonna sew up the aorta, and then now we can implant. Give me 1 second. Any questions about the anatomy itself? So this is the second common pattern, right? So after the 1L2RCx and 2R, let me just grab this.
Poteva far male.
And so hopefully by the end of this demonstration, we'll show you the PA reconstruction. Okay, I think that's pretty good. Okay, relax, yeah. Just grab this gently, yeah. Just a second, yeah. You can see that now aortic root is much bigger than the distal. Okay. Relax. Go. Just gonna see how it's gonna lay. So inevitably, there's nothing to. So there's no branches here. So this is gonna be really free and mobile. So that's actually trickier than the typical left with a circ. But this one looks like it's gonna come here. dark here.
Yeah.
Better?
Yes, better.
Okay. Now it's a 6 at the second stage.
So what's the key? Osami, you were about to tell us what the key is with the retropulmonary circumflex.
Oh yeah, so yeah, it's very tricky to avoid the kinking of circumflex. I don't think you're gonna have much difficulty on the right because right is in the same place. And just gonna show you in a 2 seconds. That should be enough. Okay. So okay. So I think yeah, so let's go through the anatomy again. So now the near aortic root is reconstructed, and let's say we took a cross clamp off. This is pressurized, and then let's take this out. Okay, so I'll just show you the coronary anatomy again. So this is pretty high bifurcation. Can you grab here? Can you see on the monitor?
Yeah, good.
So it's gonna go pretty high. So and then you see if you go to a posterior, it's gonna kink like this. I'm not sure you can see it or not, but so you wanna avoid this kind of hairpin curve. So that means you wanna have less of the angle. So to me, if I have this configuration, I intentionally tilt the tip little medial like this, like a little oblique, so that you see how this one's relatively straight. The other thing, so just mobilize, but I'll do it again. You can mobilize this branches so that there's no tethering of the circ on this side, because that will make the angle worse. Yeah, just a gent, yeah. We don't want to distort the anatomy, so yeah, that's right. So again, you don't want to go like this, right? So you want to kink. You want to go a little more like this. And then the other thing is the height, right? So sometimes it's make it better by going higher, right? Obviously, you don't want to make it too low because that will make this sort of a back off. So so I generally go a little higher so that you can kind of gently stretch the circ and then go tip medial. So I'm just gonna go this anastomosis. Okay, relax. So again, so this is okay. So this one wanna come like this. See how you have an angle there. Can you see this part? Right. So you wanna go a little like this. Okay, relax. Yeah. Oh, this is challenging because it's, but this is real because you see that this right ventricle is filled. Your geometry is completely different. So yeah, I really had to count for that. So we usually in a close technique, it's really rely on an assistant who can hold, relax, in the exactly same position. It's pressurized, right? Otherwise, yeah, so no more than that. It's just there. Okay, and then you can make a decision. Yeah, this is very challenging to. Okay, so I was thinking here. Yeah. Yeah. Yes, in even with this model, it's very difficult. Okay, so I was thinking here. Okay. Okay, now I made this incision, so we'll cross clamp again and make a trapdoor. And one important thing about this tilted incision, so you can see the incision on the monitor here. So I just tilted this way so that the coronary button sits like this. And I will make a first incision. So this is, by the way, it's very close to the commissure, so that's very common as well. And then this circle from right, it tend to come, the coronary button tend to come very medial. And relax, sorry. Yeah, okay. So just go like this. So very, and then I find that it's very important that this horizontal incision should be 90-degree angle from this. Otherwise, your coronary button doesn't tilt accordingly. So I would say, so I'm just going to go to the bottom first. But instead of going this should be 90-degree to your original incision, which is about like that. So we're butting against the marking, so we really had to look at it inside. So this time, so this is the commissure, top of the commissure. So by this point, you can actually see the commissure by direct incision, direct inspection. So it's very close. So that's why I just put this commissure sort of marking slightly higher than the actual commissure, so that you have more options. So here, okay, now we're ready to sew and see what happens with the angle. Okay. Do you do the same?
Yeah, exactly. It's beautiful.
Okay.
Yeah, it's just that slight angulation. It's not quite, as you say, just you almost rotate the button ever so slightly and lift it a bit higher up, I think.
Yeah. So it's all about the angle. So when we saw it, you can actually see what I mean. But it's a real problem, and then it does cause real myocardial ischemia if it's kinked. Okay. Can grab the button. That's right, the door. Yeah, perfect. Yeah. Again, I saw from the bottom part of the button, but obviously you can choose. Mm-hmm. Yeah, you can stay there. That's perfect. So it's about 5-6 stitches at the bottom, and if trapdoor incision is thank you. Trapdoor incision is a little smaller, which you want it. I usually go so like this, and then stretch this so that you can put everything like stuff in coronary and match the corner. This is a corner, and this is a corner of the trapdoor. Obviously, this is a right side trapdoor, so you have a very very straight lateral wall, so you can just keep sewing lateral wall. Something happened there. Let go. That goes down. Okay. Now, this, they have pickups. Yeah. Okay. Thank you. Then it goes down. Yeah. So keep sewing to the top. So once again. So follow this action. So one more stitch, and then okay. Let's swap with the. In a couple of minutes, I will show you the anastomosis. Let go with this.
Do you want me to open here?
No, just once again. Let go everything. Let go everything. Let go. Yeah, that's good. Okay, just grab.
So tomorrow when we all meet
there.
up again, it'll be the same time as today. So we'll start at 6 o'clock Eastern Standard Time. That's what 11 o'clock in the UK. No, yeah, midnight in Europe, and
Morning in China.
yeah. And then the first thing we'll do is you'll do this model with the retropulmonary circumflex. So it gives you another chance to use the models and to practice doing the coronary transfer. And this time again, just thinking about the position, particularly of this, of the sinus 2 button with the right and the circumflex coming off together.
Okay.
Again, maybe I think a lot of people were doing the open technique, but maybe if you did the open technique and you're happy with it, why not try the closed technique tomorrow?
So now I came to the top, so I'm just going to cut it. So again, you want to make it medial long and then shoulder on the lateral side. It's cutting this direction. And then finish up. Relax. Okay.
Can I ask you a question?
Yes,
so,
please.
How would you feel about making a pericardial cylinder into this position? To make a pericardial roll and to extend the anastomosis instead of direct attachments to the knee aorta?
We're bit worried about that idea because pericardial roll particularly the roll, if you make a roll, it doesn't grow, right? So soon that becomes a problem when child grows. So you want to do native anastomosis as possible, so that that anastomosis can grow with the patient. Okay. And then majority of the coronary, you should be able to anastomose without tension, right? Without the aid of the roll. Okay, that should be enough. Okay, so let's have a look at whether we did okay or not. So let's make it. Okay, so that looks okay. So we could have go a little high.
Oh, yeah, that's pretty good actually.
Yeah,
it looks nice.
see
That
how
circ doesn't look buckled or
yeah.
twisted at all. Looks right, doesn't it?
So you can see, you know, you can just hold it. Can you see on the monitor? Okay, so you see how this tricky is. So if you go up, so this looks better, and then if you go down, that looks kinked here. So that's why, so again, I tilted a little bit towards medially. That's kind of lessen the angle, and then a little higher, so that you can mobilize this part, but oftentimes it doesn't help this angle. Okay, and then quickly, we're just going to do a PA part. So I usually do this part with the heart beating, but the Dr. Baron does it sort of before implant, right? Before implant. And then Sophia from Argentina showed us a nice way, like 2 separate patches in each sinus.
Yeah.
So see let's bring it to. Okay, so we just reconstructing 2 sinuses. So we tend to sort of oversize it. Let's say because you want anastomosis to the branch PA without tension, without any tension. Okay. So let's say, so this is a circumference, right? Something like this. And we usually use the fresh pericardial patch. Do you treat?
Sorry, could I ask a question?
Yeah, go ahead, please.
Could you possibly just show how you measured that sinus again? It cut out for a bit, and
well,
I'd like to just see how you.
I don't usually measure it. You just measure it for the purpose of this particular patch. But I usually make this pericardial patch that's just like rectangle, even bigger, and then just start sewing it. And then once we get to this right-sided commissure, I just cut it out. But to make sure this is wide enough, because you want to sew the entire sort of posterior sinuses, and then high enough so that you don't make tension to the branch PA, right? So.
Okay, thanks. Thank you.
Okay.
Yep.
Okay. Let's go here. Can see it there. Okay. So just start with this corner of the left lateral. Okay. And this anastomosis is, there's some risk of bleeding just because it's not a native anastomosis, and we tend to advance on the patch quite a bit. So make sure you're taking good bite on both sides. And in the first case, to talk about negotiating tissue. So here, if you don't leave any tissue here, it's very difficult to sew to. So if you have enough sinus or coronary button, you want to leave a little bit of aortic tissue here. So this is the posterior commissure. We're just sewing towards the posterior commissure. And to deal with the posterior commissure, we have 2 ways.
Yeah,
that's okay. All right, so show you. Let's grab here. Yeah. Okay, so this is the posterior commissure. Obviously, you want to resuspend the pulmonary artery. So you can actually sew into this like this inside of the patch, which I used to do, and appears to be bleeding a little more. So now this is another common way. Is just make a slit here, and then sew to here, so that this is actually in the suture line. You don't have to cut a little bit, so do a wedge. So in the first pericardium, you don't need to do this wedge section, just doing it for because patch is a little stiff.
Mhm.
So in this way, you don't forget to resuspend the commissure. Right? So this is very important for the pulmonary valve competency. So make sure you resuspend, and then make sure you don't take any stitches on the leaflet. There you go. So you don't need a whole. Yeah, so we can cut this. So this is redundant, it's not just cutting out. And it's coming down on the other side. And Brayden, can let me know if you don't see the area of suturing. Okay. Like always have. Yeah, it's good. So just
Do you
keep,
want to follow or keep the patch?
just follow, I think.
Okay, just a sec.
This side, this side.
Okay.
Yeah. Okay. So just keep sewing. Yeah. So this is the next commissure. So we're gonna go up to the commissure. Okay. That's the bottom. Okay, so this is 1 second. So I'm just gonna show. Okay, relax. So okay, something like this. So just gonna go straight up like this, and then we can just cut. Oh, this is not too bad actually. Okay. Let's go up here, just gently. Okay, I'm just gonna cut this corner. But again, you don't want to make this too short. Okay. Yeah. And so up on the commissure here, you're very close to the valve, obviously. Just once again, just can grab this corner. Yeah. Okay, well. Good. Oh, this is okay. So let's show you. So this is how we reconstruct here. So obviously, you're gonna have to sew up this side, right? And then so this height, we'll keep it pretty high, just because if you make it too short, this one may gives you more tension to the branch PAs. So you want to have at least you want to start with a very high patch and then trim it as needed. But I'll keep it really high, at least as high as your native neopulmonary artery. And then this is what I mean by saying this is the only growing part, right? So this is the 1/3 of the original aorta, because you took out all 2 sinuses. So make sure, so when you make a button, if possible, right? So you leave a little bit of room here, little bit of room here, right? So when you cut down on the anterior aspect of the button, so that you have more room for that. Okay, so that's okay. Any questions?
Are we done?
Yeah, we're done. Okay.
Could you show, please, the LED? How do you find the place for the LED?
Okay. Yes, that's right. Yes, so LED. Okay, just grab here. So it's a. Okay, let me just. So this is it's a sort of freestanding. So sometimes it's more difficult than the having a circ. That's for that reason. If you have an anterior branch, I would definitely keep it, make it bifurcated, so that there's only one place that it can go. So if it's very long free portion, then I'll just go up pretty high. But this one, so we didn't really dissect a lot, so it's still stay the same. And if it's very long, I slightly, so just like the right side, tilted just ever slightly to the medial to make this straight. And then the rest of it the same.
I think it's always the same principles, whatever the coronary pattern is. You're just
Yeah,
trying to get a really good coronary button and let the coronary sort of tell you where it needs to be, and keep it a little bit high. If anything, it's always a bit safer. It pulls it up straight. So I think when you have this pattern, typically both the buttons are just slightly rotated. So the LED tends to be slightly more on the front of the aorta, and the circ and right are slightly more around the side. So everything's just rotated slightly. Okay, well done, everybody. We'll see you all tomorrow, same time.
Okay.
All right.
So, for hardworking surgeons, so this is the Socrates gift.
Oh, excellent. Thank you. All right. Thank you very much.
Okay, everyone. See you tomorrow.
See you tomorrow.
Okay, stop working.
Oh, thank you.
Thank you very much.
Thank you.
Muted.
Yeah, see you tomorrow.
See you
See you
tomorrow.
tomorrow.
Thank you.
Bye.
Thank you.
See
Cheers.
you.
Bye,
Good
everyone.
night.
Thanks.
Thank you. Have a good night.
Good night. Or good morning, whatever.
Mm.
Very good.
Suture their fingers to the